So, Honorable Chairman, dear colleagues, this is an overview of a policy to treat upper limb spasticity, and particularly finger flexors contracture, by patients with CNS disorder and non-functional hands based on 2 studies carried out in our service in Garches. As you know, it's possible to distinguish 2 types of function. The active functions include upper limb use, mobility, gait, and energy expenditure. The passive function include range of motion, positioning, ease of hygiene, cosmesis, orthotic fit, and pain. A fundamental point of OK, besides in the definition of a surgical goal, after questioning patient, clinical examination, functional ability assessment by a multidisciplinary team. It can be a functional goal, like obtaining grasp ability, a K grip, or improvement of hand opening time. It can also be a non-functional goal, like an aesthetic, hygienic, or an analgesic goal. If patient has realistic expectations and regarding to the surgical goal, an agreement is established with patient and or his caregivers. I allow myself to make a parenthesis about the goal attainment scaling and its interpretation. First, preoperatively, primary and secondary goals are defined with patient and or caregivers. The goal attainment is evaluated postoperatively with a 5-point scale from -2 to +2. -2 is the least favorable outcome, worse than pre-intervention. -1 means no change from pre-intervention, so baseline, or improvement towards the goal without goal attainment at the time of assessment. 0 is the expected outcome after treatment and therefore the most likely level. +1 is the better outcome than expected. And +2 is the best possible outcome that could have been expected for this goal. The overall goal attainment score is transformed into a patient T-score using the formula recommended by Kirsuk and Sherman, which accounts for variable numbers of goals and variable weightings. The mean T-score is 50 with a standard deviation of 10. You also know very well the different therapeutic options to treat finger flexors contracture. In case of a functional hand or a potential functional hand and with less than 10 degrees wrist flexion contracture with fingers extended, you can do an aponeurotomy of the epitrochlear muscles. Between 10 degrees and 70 degrees, you can perform a Scaglietti-Page procedure or a Brown procedure. With more than 70 degrees, only a Z-lengthening can provide a good correction. And by patients with non-functional hand, you can perform Z-lengthening. And by very fragile patients with only an hygienic goal, it's possible to perform percutaneous sternotomies. But what's the best option to preserve muscular strength by patients with functional abilities? The choice between the different techniques is based on the severity of the deformity and the surgical goal. As you can see on this slide, the proximal release, according to Scaglietti-Page, is the best balance between efficiency on spasticity and contracture, the muscular strength preservation, and the recurrence risk diminution. The different therapeutic options will be explained by François Genet after this presentation, so I only focus on the Page technique. After a ulnar side forearm incision, all the epitrochlear muscles are released from the proximal insertion on humerus, ulna, and enterosus membrane. It's very important to preserve ulnar, median nerve, vessels, and nervous branches to the released muscles. Depending on preoperative pronospination status, the prenatal teres is released with the fingers flexor or not. So you understood that at Garches we prefer the Scaglietti-Page procedure in patients with functional abilities or functional potential. And here are the results of a retrospective study that we carried out. The aim of the present study was to assess the amount of increase in extension and the improvements in global hand function that can be expected following this lengthening procedure in patients with CNS disorder. All patients had contracture of the wrist and extrinsic finger flexors muscles, and in some cases with forearm pronator muscles contracture, causing functional and aesthetic or hygienic impairment. All patients had functional abilities or functional potential, even if some of goals was aesthetic or hygienic goals. Thus, in all cases, the page scalability technique was performed. And before surgery, the motor nerve blocks were used to distinguish between spasticity and contracture, with surgical intervention only for contracture. The data of 50 patients were included during the study periods, representing 54 hands. And the mean follow-up was 26 months by surgeon and more by PMR physician. The wrist extension was significantly increased, with a mean gain in wrist extension with finger extended was 67. The two next slides shows the results of the Dankoli classifications and House classification preoperatively and postoperatively. Improvements were significant for both scales following surgery. These figures summarize the results for the Dankoli classification. None of involved hands were classified as Dankoli Group 1 before surgery, whereas 25 hands were classified as Dankoli Group 1 at the latest follow-up assessment. This figure summarizes the results for the House classification. And 8 patients with an initial hygienic and aesthetic goal gain additional functional abilities, and these patients were classified as House Groups 3 and above. In 12 cases, partial recurrence of the deformity occurs, and 8 cases were managed by surgical revision, 4 through a non-surgical approach. In 7 of these cases, surgery unmasked spasticity of or contracture of muscles, which required further intervention. 3 surgical revision, and 4 were managed through a non-surgical approach. As a conclusion, page scalability technique appears to improve range of motion and function in people with wrist and finger contracture due to central nervous disorders. Now let's talk about the non-functional spasting hands with a preview of a retrospective study carried out by our colleague Laure Gatin. The aim of this study is to evaluate the short-term results of surgical interventions of the soft tissues for different types of upper limb deformities in which the goal was purely perceived relative to 3 main goals selected by the patient and caregivers: hygiene, appearance, and pain using goal attainment scaling. One primary goal was determined by consensus with the patients, their caregivers and families, and the healthcare team using goal attainment scaling. A list of 3 goals were proposed to help to determine the primary goal: facilitate hand hygiene, decrease spontaneous pain or pain during mobilization, and improve appearance. 1 primary goal and up to 2 secondary goals were chosen from this list. Improvement was evaluated by patients and our caregivers at the 3 months follow-up. Also, the aim of the intervention was not to improve function. The House functional classification was rated prior to surgery and 3 months post-operative in order to assess if any functional improvement had occurred. So 63 patients, including 23 women bilateral in 5 cases and 40 men bilateral in 2 cases, were included. The mean age was 51 years old. The main etiology was stroke in 35 patients, followed by traumatic brain injury in 16 patients, cerebral anoxia in 4 patients, neurodegenerative disease including multiple sclerosis, in 6 patients and cerebral palsy in 2 patients. The primary goal was for the 70 procedures was to improve hygiene and in 58 cases, reduce pain in 10 cases, and to improve appearance in 2 cases. Among the 63 patients, 51 patients chose a second goal for 54 cases, including bilateral surgery. Among them, 4 was hygiene, 33 was pain, and 17 was appearance. And for 13 cases, patients chose a third goal. It was pain in most cases. Both the intrinsic and extrinsic muscles were effective in 55 hands, 53 of which underwent surgery to both the intrinsic and extrinsic muscles, and 2 of which only had surgery to the intrinsic muscles. I do not detail the interventions carried out because most interventions have already been described in the literature. So the most common deformities of the upper limbs in adults in this series with CNS disorders are first the flexion contracture of the fingers in 100% of patients in this series, then the flexion contracture of the wrist in 63% of patients, and last, the flexion contracture of the elbow in 9% of patients. The minimal follow-up by the surgeon himself was 6 months, and largely more by the PMF physician postoperatively, minimum 3 months after the surgeon. The mean GAS score increased by 1.3 for hygiene, almost 1.1 for pain, and 1 for appearance. The mean total goal attainment scaling score increased by 1.18. And taking into account the weight of each goal at 3 months post-operatively, the T-score reached 52, corresponding to a better than expected outcome according to the goal attainment scaling method of interpretation. 9 hands required at least 1 additional injection of botulinum toxin post-operatively, and 40 patients underwent botulinum injection pre-operatively because botulinum toxin was no longer required for the operated hand. The dose could be redistributed to other muscles of the same upper limb or other limbs. So, soft tissue surgery can effectively improve hygiene, pain, and appearance in adults with CNS disorders. The preoperative evaluation should be multidisciplinary, and goal attainment scaling is a useful tool to assess the effectiveness of surgery for these patients. Surgery does not necessarily mean the end of the treatment for patients with CNS lesions, as post-surgical changes allow new objectives to be determined, which can be attained through further pharmacologic treatment and rehabilitation. So, surgery has its place among the therapeutic options for taking care of non-functional hands in adults with CNS disorders. And for functional or potential functional hands with finger flexor contracture, the Scaglietti-Page procedure is, from our experience, the best balance between efficiency and spasticity and contracture, the muscular strength preservation, and the recurrence risk diminution. Thank you for your attention.